My name is Dr. Geeta Sinha. I'm in the Department of Anatomy and Neurobiology with the Faculty of Medicine. This is the third video of my Pelvis and Perineum series. In this video, I will be talking about the nerves of the pelvis and perineum, the somatic nerves as well as the autonomic nerves. There is special animation here for the maturation and genital reflex, especially talking about the spinal cord injury and its effect onto the maturation and the genital reflex. Now, with the help of a prosection, I am going to demonstrate some of the somatic nerves in the region of the pelvis and perineum. These nerves originate from the lumbar plexus and sacral plexus. The lumbar plexus is formed by the ventral rami of L1 to L4. Sacral plexus is also known as lumbosacral plexus, originate from the L4-5 and S1 to S4. These nerves supply the sensory and the motor area in the region of the perineum, also some of the walls of the pelvis. So on this hemisection of the pelvis, I'm going to show you some of the branches from the lumbar plexus. These are the nerves which are going to supply the skin over the perineum. The particular nerve which we are looking is ilioinguinal, genitofemoral. Also, we would like to see the obturator nerve because this nerve lies in relation to the ovary. Let's orientate ourselves. This is the crest of the iliac crest. We are looking at two nerves here. The first nerve which I am pointing is iliohypogastric nerve. That is the first branch coming from the L1. The second branch which I am looking here, which is running around the crest or over the crest, is ilioinguinal nerve. This nerve will come along the anterior part of the inguinal region, and it supplies the anterior 1/3 of the scrotum around this area here. This is mostly sensory to the scrotal skin. The second branch which I am looking over lying on the psoas muscle, this nerve which is running over the psoas is genitofemoral nerve. If I follow this nerve, this divides into two branches, a femoral branch and a genital branch. The femoral branch will supply the skin over the anterior part of the thigh, the areas around this region. Especially in the male, the genital branch supplies the cremasteric muscle, and this nerve is responsible for the cremasteric reflex. The cremasteric reflex is when you stroke the skin on the medial side of the thigh. You notice the testicles are moved upward, and that it is very important sort of spinal level testing for L1 and L2, and it's much more used in the babies. If we go on to the lateral crease of the psoas muscle, we see very big nerve here. This nerve is coming from L2-3-4 level. This is the femoral nerve, and the femoral nerve supplies the anterior part of the thigh, most of the muscles in the flexor compartment. Another nerve which we can see around here, which is nothing to do with pelvis, this is the lateral cutaneous nerve of thigh, which is passing over the iliacus muscle. Now on the medial crease of the psoas muscle, coming out from L234 level, this is the obturator nerve. The obturator nerve follows around the pelvic brim or inlet and passes through the obturator foramen to reach the medial compartment of the thigh. It runs with the obturator artery. The clinical importance is that it relies in the relationship of the ovaries around this area. And in female with a ovarian cyst, it can compress this nerve, and a patient can present with the pain on the medial aspect of the thigh, while the pathology is lying into the pelvis. So this is the obturator nerve. On this model, let me show you the course of the pudendal nerve. The pudendal nerve is formed by the ventral rami of S2, S3, S4. So these white wire coming from the anterior sacral foramina of the sacrum, they join in together to form this wire represent the pudendal nerve. The pudendal nerve then leaves the pelvis through this big opening, which is the greater sciatic foramen. On the posterior aspect of the pelvis, I pick up this wire, which is represent the pudendal nerve, coming in the gluteal region, and this area here represent the sacrotuberous ligament, and this area white flap represent the sacrospinous ligament. The nerves then passes through the lesser sciatic notch to enter the region of the perineum. This is this diamond shaped area here. It passes along the side of the ischiopubic ramus. In this area here, it is covered by the obturator fascia. This layer of the obturator fascia makes a canal. This canal is known as pudendal canal. It's also known as Alcock's canal. And in this area here, the nerve can be anesthetized. In the pudendal canal, it gives three terminal branches. The inferior rectal nerve, which supplies the anal triangle. The perineal branches, which are not shown in here, will be going into the superficial pouch and the deep pouch and supplies the contents in this area. While the third branch, which is this nerve, which we are going to follow up on the superior aspect of the urogenital diaphragm, this nerve represents the dorsal nerve to penis or clitoris, and this will pass over the dorsal surface of the penis and clitoris and supply the skin over that area. The next important nerve which supplies the extensive area of the perineum is the pudendal nerve. Now pudendal nerve is a branch coming from the sacral plexus, and sacral plexus is formed. We can see the sacral formation of the sacral plexus on the anterior aspect of the sacrum. formed by the ventral rami of L4, 5 joined together. This is lumbosacral trunk, S ventral rami of S1, ventral rami of S2, S3 and S4. And the pudendal nerve is a branch coming from the S2, S3 and S4. If I turn this pelvis on the posterior aspect, we can see the pudendal nerve exits. Here is the nerve which is exiting from the greater sciatic foramen, which is this big opening, and re-enters the perineum through the lesser sciatic foramen, which is this opening around here. And that is your pudendal nerve. The pudendal nerve enters the perineum through the lesser sciatic notch and passes along the ischiopubic ramus, where it passes through a fascial canal, and that canal is known as pudendal canal or Alcock's canal. The nervus is anesthetized in this area here. In this canal, which is formed by the fascia of obturator internis muscle, it divides into 3 terminal branches. The first branch, which is given in the anal triangle, is the inferior rectal nerve, and the 2 branches which will continue on the urogenital triangle is the perineal branches and the dorsal nerve to penis or clitoris in female. Another nerve which is, we can see some of the fibers of this nerve here. This is the posterior cutaneous nerve of thigh. This gives a perineal branch, and the perineal branch supplies the posterior 1/3 of the scrotum in case of male. In case of female, it supplies the posterior part of the labia majora. It's not that important a nerve. The main important nerve in the perineum is the pudendal nerve, because that supplies the sensory and motor in the region of the perineum. Let me demonstrate the autonomics of the pelvis and perineum. The sympathetic and parasympathetic in this region are the continuation into the abdomen. But some of the fibers, they originate in the region of the sympathetic chain, in the region of the pelvis, and parasympathetic fibers, they originate from the spinal cord at the level of S2, 3, 4. Sympathetic and parasympathetic fibers, then they form a plexus on the side of the rectum on the right side and the left side. These plexes are known as right and left pelvic plexus. The fibers then distributed along with the blood vessels to the different internal organs in the pelvis. Some of these nerves also distributed to the erectile tissue into the external genitalia. I'm going to also explain the maturation reflex and the genital reflex, and clinically any injury to these nerves, what is the effect on the maturation reflex and on to the genital reflex. On this hemisection of the pelvis, I'm going to demonstrate the sympathetic chain, few sacral splanchnic nerves, pelvic splanchnic nerves, and formation of the pelvic plexus. That is the anterior surface of the sacrum, sacral promontory, pubic symphysis. And now I am pointing, this is a ganglion here, and this is the sympathetic chain, the sacral part of the sympathetic chain, all the way up to the, probably this is where it will finish and form the, attached to the ganglion impar, which is the last ganglion, where the right and left side of the sympathetic chain meet. The fibers which are coming in here, these are the fibers which are the probably part of the sacral splanchnics. And we also see these are the fibers which are coming from S2, S3, S4 level. These fibers, these are the pelvic splanchnic nerves. These are the parasympathetic contribution which originates into the spinal cord at the level of the S2, 3, 4, and they leave the spinal cord from the ventral rami, and then they leave the ventral rami and form with the sympathetic fibers, they form the pelvic plexus on each side of the rectum. Here is the rectum. We can see the lower part of the rectum and the anal canal. Any operation in this area can cause the injury to the pelvic splanchnics, and the effect of the injury to the pelvic splanchnic nerves can have effect on the maturation reflex, the genital reflex, or on to the defecation reflex. These fibers of the sympathetic and parasympathetic, then they wind around the arteries and reach to all the internal organs inside the pelvis, that is the bladder, in case of male, or the seminal vesicle, the vas deferens, the prostate, and the part of the rectum. In case of female, it will be also going into the uterus, the vagina, the uterine tubes, and as well the fibers will also pass through the with the internal pudendal artery and reach the erectile element of the penis, and in case of female, the bulb of the vagina and the crus of the clitoris, as well as the body and the glans of the clitoris. So this finishes the demonstration of the autonomic nerve supply of the pelvis and perineum. In adult, as the bladder fills with the urine, and once the volume exceeds approximately 400 to 500 cc of urine, the pressure inside the bladder increases. The stretch receptor in the bladder are stimulated by this pressure. Their impulse is carried by to the spinal cord by the sympathetic and primary via the parasympathetic nerves. Those are the pelvic splanchnic nerves. From spinal cord, the impulses travel to pons and cerebellum and the cerebral cortex, and that is for the conscious control. This creates the desire to maturate. If it's not a socially accepted place or time, the brain sends impulses to inhibit this response by the sympathetic and somatic nervous system. Once a socially accepted place and time is found, the inhibition is lifted and brain sends information or impulses through the parasympathetic nervous system. During the voiding or the being phase of maturation, the parasympathetic system is active. In babies, before they are toilet trained, the maturation is a reflex action. Babies have no conscious control over the maturation. Instead, they use the diapers. Toilet training, that is the learning to restrict urination to a socially accepted time and place, is achieved around the age of 2 to 3 years old. So in the babies, the bladder fills with the urine. The impulses via the sympathetic and parasympathetic fibers reach to the spinal cord that stimulate the parasympathetic response via the pelvic splanchnic nerves, which starts the contraction of the bladder, and the urine is expelled from the bladder. There is no inhibition reflex at all for a socially accepted time and place. This is almost a automatic bladder. In this presentation, we are going to see the effect of the spinal cord injury above the S2-3-4 segment. If there is injury into the spinal cord above the S2-3-4 level, that produces a type of bladder which is found in the babies, which is called as automatic reflex bladder. Basically, in this injury, the connection from the brain is gone. So there is no voluntary control on the maturation and no control of the time and the place. In this condition, the patient will wear a bag and can empty it at a certain time. The injury to the sacral level of the spinal cord at S2-3-4 level produces autonomous bladder, and this is with the flaccid bladder wall, because parasympathetic fibers, they supply the detrusor muscle of the bladder. Without any innervation to the detrusor muscle, the walls of the bladder become flaccid and they increase in the capacity. And it also has no contracting power, so it leads into continuous dribbling. In these patients, there is always residual urine inside the bladder, and because of the constant use of the catheter, there is a continuous urinary infection. During the genital reflex, there are two phases, the erection phase and the ejaculation phase. Ejaculation phase follows the erection phase. The erection phase is because of the stimulation of the parasympathetic fibers. Ejaculation phase is because of the stimulation of the sympathetic fibers. The brain is the main focal point which has to understand which phase the body is going through. During the genital reflex, in men or in women, the stimuli can be received from the higher center, which is the visual, olfactory, auditory, psychological, or from the cutaneous zones, example, the nipple, the back of the neck, and from genitalia. These efferent fibers can reach the brain via the somatic, sympathetic, or parasympathetic nerves. There is also a center in the sacral part of the spinal cord for the erection. Once these fibers reach to the brain, it starts the process of erection. The parasympathetic fibers, in response to that, to these stimulation, cause the vasodilatation of the Helsine arteries of the penis, and in case of the female, in the clitoris. Thus, there is increased blood volume into erectile element of the penis or clitoris. Because of the engorgement of these arteries, the veins get compressed, and that causes the erection. Increased afferent stimulation results into the activity of the efferent sympathetic fibers, which supply the smooth muscles of the vas deferens, prostate, epididymis, and seminal vesicle, and that leads into ejaculatory phase. The sperm from the epididymis starts flowing to the vas deferens. The contraction in the smooth muscle of the vas deferens will take the sperm to the ejaculatory duct, and by the smooth muscle contraction of the seminal vesicle and the prostate, the fluids from these two glands are added with the sperm, and the formation of this semen is passed through the urethra. At the end of the phase, the impulses in the efferent fibers of the pudendal nerve, it causes the contraction of the bulbospongiosus and ischiocavernosus muscle, which helps in expelling the semen from the penile part of urethra. The effect of the spinal cord injury on the genital reflex. The injury above the S2-3-4 level that disconnects the brain from the sacral part of this spinal cord. The impulses from the local stimulation can reach and can cause the efferent parasympathetic fiber to stimulate the vasodilatation of the Helsinki arteries, and so the erection can happen. But as the brain is disconnected, the ejaculation may not follow immediately. In some patients, it can happen later, but it's not a continuous process. Spinal cord injury to the S2-3-4 level disconnects the parasympathetic fibers. So the impulses cannot reach to the erectile tissue. That means there is no erection. If there is no erection, there is no genital reflex at all, and it leads into impotence.